Welcome everyone to this webinar looking at the guidelines for pre-referral rectal artesunate implementation at a community level that we are launching. This is co-organized by Medicines for Malaria Venture and Transaid, and it is my pleasure to be chairing this webinar. My name is André Chouatieu, and I work with MMV. I'm a physician working with MMV as Director of Access and Product Management. And it is really my pleasure to welcome all colleagues connected here. I know we have partners from malaria programs connected, various organizations that are supporting and collaborating with countries in implementing malaria programs across malaria endemic areas. So welcome, and thank you to have taken on your precious time to spare these 45 minutes with us today. We'll start by having a bit of a context of the malaria, the severe malaria. This was supposed to be given by a colleague of mine, Hans Hetfield, who is not available today, and I'll step in for that. Then there will be introduction to the guidelines by Cathy Green from Transaid, highlights and innovation in the management of severe malaria by Ernest Chanda from Transaid as well. Then we'll have a Q&A session managed by Caroline Barber from Transaid. And then we'll go into impact and where to obtain the guidelines, the way forward, and closing comments. And all this, I'll be coming back again to do these two last steps. So thank you once again for your time. And I think without further ado, let's move to the context of severe malaria, please. Next slide. So as we all know, the latest malaria report reported about 597,000 children or people who died from malaria, from severe malaria in 2023. And among those, there were 440,000 children under 5. The focus on the 5 years here is because our main topic today is the use of rectal artesunate to the management of severe malaria for pre-referral. And we all know that it is indicated in that age group. Severe malaria, it's unfortunately increasingly overlooked by policymakers. Although if we all want to attain the objective of malaria elimination, I think one of the starting points is definitely to start by decreasing malaria death up to 0. And this was reminded to all of us during in January 2024 during a meeting organized in Yaoundé for grouping together all the high burden countries. And the declaration there was really to push the agenda to zero death from malaria. So that was a key reminder, and rectal artesunate definitely should play a bigger place in this objective of 0 death from malaria, especially in remote areas where most of the time health facilities are not available, are not at the next door, and there is a need for a rapid solution to prevent death from these severe cases. 1 to 3% of uncomplicated reported malaria cases were estimated to have advanced to severe disease. So with 50 to 80% of those cases estimated to have been hospitalized. So it's still a very concerning case, the management of severe malaria. And at community level, as I was saying, the parenteral drugs is not possible to be used because most of the time health facilities are very far. So there is a need for an intermediate solution, and rectal artesunate has been there and demonstrating 25% reduction of mortality. Next slide, please. So comparing the evolution of the policy and over the years, and associating to that the level of consumption, if I may say, of rectal artesunate, we could see that the first recommendation of rectal artesunate as a pre-referral treatment occurred around 2006. Then there was a control trial that reported that pre-referral rectal artesunate was shown to reduce mortality and permanent disability. And this occurred around 2009 with the first orders of rectal artesunate there. Then 2 rectal artesunate products were WHO pre-qualified, and this was in 2018. That boosted the orders of rectal artesunate, and countries started consuming. And we saw this consumption growing up to 3 million, up to around 3 million doses. And that coincided with WHO issuing restrictive information notes on rectal artesunate, mainly making sure that the continuum of care is followed, which sometimes is not possible. And then in 2023, 2 years ago, WHO issued an updated information note, but we are seeing after the restrictive information note a drop in the consumption of rectal artesunate, though this is still a life-saving drug that needs to be promoted. And this is why these guidelines have been developed. And I will leave our colleagues from Transaid to continue with the next presentation from here.
Thank you
Kathy,
very much. Thank you very much, Andre. Thanks very much. So good afternoon, everyone. My name is Kathy Green, and I work for Transaid as an Associate Access to Health Advisor. So I'm going to be giving a little bit of an overview of the community RAS guidelines this afternoon, and just to say that we're absolutely delighted to be launching these today. And I just wanted to start by thanking Brigade Electronics. This is a UK-based company who very kindly designed the guidelines for us professionally on a pro bono basis, and I think they look wonderful. So thanks very much to the Brigade team. So I wanted to start with a little bit of background. I'm sure that many of our members of our audience today are aware of the WHO Field Guide on rectal artesunate. This was produced in 2023. The guide provides really timely overarching guidance to support the effective deployment of RAS in line with WHO malaria guidelines. And it covers really important topics such as the need to revise national malaria guidelines, to include RAS on essential drug lists. It focuses on planning for RAS implementation and looks at the roles and responsibilities of government and other bodies at different levels, from national level downwards. And it looks at the importance of commodity and supply chain management. So the new MMV guidelines are intended to complement the WHO Field Guide, and the idea is that they are used together. So we were aware that some countries were requesting additional, very practical, step-by-step guidance on how to design and implement a RAS intervention at local level in rural settings. And our team and partners in Zambia, the National Malaria Elimination Centre and district health management teams, had a lot of experience of implementing a community RAS intervention in remote parts of Zambia. And we felt that there was a really good opportunity to share this experience. Next slide, please. So why do we draw on Zambia's experience of implementing RAS? Let me provide a little bit of background here. Zambia's RAS pilot was implemented by the National Malaria Elimination Centre, which is part of the Ministry of Health, by district health management teams and a consortium comprising Transaid, Development Data, Disacare and Dye Global Health. Funding for the pilot was from Medicine for Malaria Venture. So the pilot intervention was implemented in a single district and covered a population of 54,000. And this was over the period 2017 to 2018, so just a single year. The intervention was later scaled up to cover 10 districts over the period 2018 to 2021 and covered a population of 900,000. Both the pilot and the scaled up intervention demonstrated the feasibility of training community health workers to administer RAS in hard to reach areas. So these two interventions, they trained community health workers to mobilize their communities around a malaria agenda. They trained community health workers to work with their communities to address some of these very profound household and community barriers and delays to the use of severe malaria services. Clearly, they trained the CHWs to administer RAS and to refer to a health facility. They supported the training of frontline health workers to appropriately manage severe malaria, and they placed a major focus on improving supervision of community health workers. And finally, they generated reliable data at health facility level and at community level to show that the intervention was working. And the results speak for themselves. The pilot led to a more than 90% decrease in reported case fatality rates from severe malaria in intervention sites. So the rates fell from 8% at baseline to 0.5% at endline. With the larger scale intervention, the scaled up intervention, there was an 84% decrease in reported case fatality rates seen in 2 demonstration districts and a 90% decrease from 6.2% to 0.6% in 8 other districts. So the approach used in Zambia is considered to be very adaptable to different contexts and thought to have a great deal of potential to use in other countries, both within and outside sub-Saharan Africa. And at this point, we'd like to play a short video which introduces the community RAS work in Zambia. And this was produced with the support of the Gates Foundation.
Okufuma obushiku bw'amairo omwana alisa alwala omubiri we alisa akabasana alisa afirwa n'okulya n'ebyakulya efa n'akiisa afika nakuli bakome kishinka bamupima n'omulopa bamusanga n'obulwere buntu bakimusanga nabo.
Severe malaria, if left untreated or unchecked, can result in death, especially within the first 24 hours. The majority of lives lost to malaria are those of children who live quite far from health services.
How do you save children who are living in remote communities who are suffering with severe malaria?
Here in Zambia, we're using an already existing form of anti-malaria treatment, artesunate. In this case, it's in the form of a rectal suppository. This is a life-saving form of drug. The initial dose allows time for the sick child be transported from the remote area that they're coming from to the health facility where they can access more treatment.
Zambia is a very big country with about 752,000 square kilometers. Some villages can be as far as 50 kilometers to a health facility. If you have to get the child to the health facility in time, there must be a transport system in place. These bicycle ambulances are a much better mode of transport because they need to be transported in a very, very proper way so that you don't complicate the condition.
By the time they are reaching the health facility, at least they are stabilized. Now at the facility, we usually give injectable artesunate in order to complete the treatment.
Lero n'akireeta omwana ku kipataala n'akimuleeta n'okumundapa bamundapa n'omwenso nshikweto bakwe batikutyawo nayika.
Since the introduction of this anti-malarial drug, we've seen a huge reduction of death in children under 5 in remote areas.
By improving access at community level, we can save more lives, which has been proven already in Zambia. Now that there's a World Health Organization quality assured rectal artesunate suppository, this has the effect of improving our fight against malaria. Currently, 29 countries have introduced this form of treatment. This is one of many innovations that we need in the next 5 years in order to beat malaria.
So, as more countries begin to implement RAS, the idea is that the guidelines can be updated to include additional case study material and also adapted wherever appropriate to incorporate lessons learned and new material. So our hope is that the guidelines will become a really useful part of the toolkit of resources that countries planning to implement RAS can use. Next slide, please. So the main audience for the guidelines, or audiences for the guidelines, are as follows: Ministries of Health in high burden malaria countries, national malaria programs, child health and integrated community case management personnel, subnational health teams at provincial, state, district and local government levels, and of course development partners supporting the rollout of community RAS. So really, we're looking at a really very practical set of guidelines that can be used on the front line of implementation. Next slide, please. So how did we develop the guidelines? They were drafted by a team from Transaid. That includes myself, my colleague Ernest Chander, and Caroline Barber, who is the CEO of Transaid. But a broad range of stakeholders played a really key role in helping to shape the guidelines. We went through quite an extensive peer review process. We invited public health, malaria, community health systems, community engagement experts, and also staff of national malaria elimination programs to review the guidelines, which were adapted in response to feedback. We're really grateful to all the reviewers, and they have, of course, been acknowledged in the guidelines. Next slide, please. So a little bit about the content of the guidelines. There are 10 sections. The first provides advice on selecting intervention sites. This asks, what are the main criteria to take into consideration when planning a community RAS intervention? What are the primary criteria and what are the secondary criteria? The primary criteria are locations with a high burden of malaria, rural, remote and hard to reach areas, and communities that struggle to reach a health facility in less than 6 hours. And examples of secondary criteria would be sites with a trained community health worker team, sites that can be provided with a consistent supply of RAS, and sites that have a functional health facility within 10 kilometres. So this section really provides a detailed overview of all the factors to take into account when selecting intervention sites. And I think the key message here is careful planning at the outset is a really important first step. There's also a section on designing and delivering training to community health workers. This looks at what needs to be included in the training and at how the training can be delivered. So this section asks, what are some of the evidence-based methods and tools that can be used to deliver the training? And a key consideration in this section is how to shift the emphasis within the training from a classroom-based, more didactic approach to a more participatory training approach that is relevant and appropriate for a low literacy audience. So there are also sections on how to prepare communities for the introduction of RAS, with a focus on designing community engagement and mobilisation activities. There's a section on addressing household and community barriers and delays to the use of severe malaria services, which is really important, and on designing patient transport systems to support rapid referral. All these topics are crucial aspects of a community RAS programme. There are also sections on designing severe malaria training for frontline health workers. It's really important to ensure that all health workers who will be managing cases of severe malaria or suspected severe malaria have a refresher training and understand how to appropriately manage cases. And that includes how to administer injectable artesunate. The guidelines also include a section on effective and supportive supervision of community health workers, which we know is absolutely fundamental to their motivation and retention. And there are lots of practical tips on how to provide supervision in contexts where health budgets may be very constrained, so working opportunistically. Finally, there are sections on monitoring and evaluating RAS at community and health facility levels, and planning and budgeting for a RAS intervention. Next slide, please. So the guidelines are written in plain English. They're designed to be very practical with a major emphasis on how to. They include many checklists of issues to consider and some interesting case studies to illustrate key points. There are also summaries in some of the key subsections of the key points to remember. The guidelines as a whole are written in such a way that they can be adapted for different contexts, and they provide options and issues to consider rather than a definitive approach. And interestingly, the community health worker training resources have just been adapted for use in 5 states of Nigeria, and that was just last week. So there are 14 annexes, which include resources such as the community health worker training materials, supervision checklists, M&E forms, and guidance on costs to consider when putting together a RAS implementation budget. So pretty comprehensive. So that was a very quick overview of the content of the guidelines. I'm now going to hand over to my colleague Ernest Chanda, who is one of the authors of the guidelines, and he was Transaid's technical coordinator for the 2 Zambia RAS programs. And Ernest has worked very closely with the Ministry of Health and district health teams in Zambia to support implementation.
Thank you, Kathy. Thank you, everyone. Good afternoon. My name is Ernest Chanda, as area introduced by Kathy. I'm also coming from Transaid, and I'll be discussing some of the key features of the RAS intervention in the guidelines, and I'll focus on the 6 aspects. Yes, as area mentioned, the guidelines are quite comprehensive in the sense that they cover almost all the aspects of the RAS implementation at community level, and this means beginning from selection of intervention sites. Those are communities to participate in the intervention, and also training of community health workers, training of health facility staff at primary health centers, and also goes to designing of monitoring and evaluation strategy, systems, as well as planning for budgeting for the RAS implementation at community level. And as my colleague area mentioned, Kathy, yes, the guidelines complement the 2023 World Health Organization guidelines for RAS implementation, and these can be used in conjunction with this. The guidelines also focuses on the crucial role that community health workers are involved in. That is the last implementation that is beginning to understand the importance of receiving appropriate training. And this is the training that will allow community health workers to adequately implement the RAS program at community level and also receive an effective supervision strategy. The guidelines also emphasizes on the importance of community health workers to be trained in 2 components of the training. And this is receiving training in both severe malaria case management component, as well as the component community mobilization, so that they are able to, they get a great understanding in how to administer rectal artesunate, as well as on how to mobilize the communities so that they are able to detect the signs and symptoms of severe malaria and refer the cases within a short period of time. The guidelines also provides the detailed understanding on the resources of the training, and that is looking at how the training is delivered, how the training methodologies are delivered, and also how to access the training and how to enjoy it, the facilitation skills and so forth. The guidelines also emphasizes on the importance of bringing community health services closer to the doorsteps of people. that is, community health workers are adequately trained and they share the information within the communities, and that makes health services close to the people within the communities. And whenever there is an emergency, a malaria emergency, communities will make quick decisions to launch their children to the health facilities for treatment, and where they will find well-trained health personnel. So in Zambia, we've been lucky. NMEC ensured that staff at primary healthcare level are trained in the use of artesunate injectable, or let me say in malaria, complicated malaria management. And that has really been of help, because children referred from communities did not take time to receive treatment at PHC levels. The guidelines also addresses the demand side, and that is providing the practical advice on how communities can address demand side barriers. In Zambia, some of the barriers that were identified were communities could not access health services on time due to lack of transport, due to lack of food, due to lack of childcare schemes in some of the communities, as well as distance due to lack of transport, and also due to lack of male involvement in the community awareness activities, as well as violence against women and girls. And some of these were addressed by community-led initiatives, and that is communities came up with community saving schemes, those for families that were affected by socioeconomic challenges. They had at least access to community saving schemes, and families were supported with some money to use for transport, as well as money to use while at the health facilities, and also money to use on the way to the health facility. And that encouraged many mothers to access health services. And also ensuring that they came up with community food banks. That is one of the initiatives, as well as community child care schemes, looking at a group that is taking care of children whilst their mothers have taken their fellow children to the health facilities. And the guidelines also looks at the importance of male involvement. Male involvement, ensuring that men participate in the community group discussions where volunteers are discussing issues to do with where gender-based violence is condemned, and where they're also discussing issues to do with quick leaf flow systems and so forth. The guidelines also addresses the leaf flow delays caused by physical access barriers. And as some of you may know, we have the evidence that due to lack of good transport systems, negatively affects the health outcomes of children due to lack of transport. They don't have means of transport. So the guidelines looked at how to address some of these barriers, and it includes the detailed information on how to address issues to do with the transport and also accessibility barriers. The guidelines also provide solutions on how communities can carry out baseline transport assessments on their own, and also assessments within their communities, and also looks at how communities can come up with emergency health evacuation plans, and also ensure that communities are well prepared to respond to emergencies, and also ensure that they come up with a bicycle, they come up with a means of transport. For example, in Zambia, they came up with a means of bicycle ambulance, depending on the culture within the community. And that is the means of transport that will be used 24-hour service. And whenever there is an emergency, a patient can quickly be rushed to the health facility. And depending on the culture within the community, in Zambia, what was common was the culture of bicycle ambulance was used, as some of you might have watched in the video. And also in other countries, there are other means of transport, like in Nigeria, they have used other transport, like a tricycle. We were in Nigeria 2 weeks ago, just that last week, and we saw the tricycle has been used before. In Uganda, the other means of transport, and also in Madagascar. The guidelines also focuses on gender and social inclusion, ensuring that volunteers are trained to ensure that socially excluded families are brought on board, and also ensuring that there is gender balancing in the training of our community health workers, so that there is representation from both the female and the males. And also the guidelines also strongly emphasizes on the male involvement, as earlier stated, and also addresses also the issue of gender-based violence. Those are some of the issues that prevented timely access to better health services. The guidelines also ensures that everyone in the community is involved in the community activities, so that decisions can quickly be made within a short period of time and avoid the delays. So these are some of the 6 aspects that I have focused on, and these are some of the aspects that can help in the successive RAS intervention. I will hand over to Carlo. Thank you.
Thank you very much, Ernest. So my name is Caroline Barber. I'm the Chief Executive of Transaid, and a very good afternoon, and indeed from colleagues joining from the US, a good morning to you all. It's my privilege to facilitate the question and answer session of our webinar today. And I would encourage those of you who haven't already to put any questions into the question and answer function. You can also put questions in the chat, and I know other questions are starting to come through. So I will start with the first question. Of course, people are asking, how can I get hold of these guidelines? And we will be sharing the links to that in a moment. We have a question here that's come through that is asking, will the community RAS experience in Zambia be relevant to other countries? So I think I'd like to direct that first question back to Ernest. Ernest, over to you.
Sorry, would you repeat the question, Carlo?
Of course, Ernest. The question is about how relevant the community RAS experience in Zambia is to other countries.
Okay. RAS experience is being relevant to Zambia in the sense that I think the priority target has been using RAS in remote communities, where families have to walk longer distances to find health services. And RAS has effectively been used by ensuring that it buys time for the child to survive before they reach the health facility for completion of treatment. And that has helped many children's lives, which we could have lost had it not been the use of RAS. And it's relevant to other countries in the sense that those countries do have communities that are far away from primary healthcare centers as well as secondary healthcare centers. So that's my response to the question. Thank you.
Thank you very much, Ernest. We have another question, which is, how was the WHO involved in the development of these guidelines? I will start by inviting Kathy Green to respond to that question.
Thank you very much indeed. We had a very extensive peer review process, as I said earlier. We invited a number of individuals from different organisations to review the guidelines, an early draft of the guidelines, and we indeed shared the guidelines with WHO. So we've had, very strong input from, a wide range of experts from many different organisations.
Many thanks, Kathy. We have a couple of questions here about the approach and about the use of RAS. So I probably think that Andre is the most appropriate person to respond, but let me ask the first question, and of course other colleagues on the panel, please do respond too. The question is, what is the emphasis on the use of ACTs in combination with RAS? Perhaps Andre, you could take that question.
Yes. Today, the normal recommendation for when the health system allows, after referral, there's management of severe malaria through injectable artesunate at health facility level, and then it is recommended as soon as the child can swallow to follow up with an entire cure of ACTs. So that's the normal recommendation when the referral system is in place and when all the conditions are in place. In case now, in worst case scenario, when referral is not possible, following up on rectal artesunate, with ACT remains possible when the conditions are not in place and the referral is not possible. So this is in practical situation when the referral is not possible, and there shouldn't be any issue of behaving this way.
Superb, thank you. And staying on the sort of more clinical questions, there's a question about side effects. What is or are the key downsides or side effects with RAS use, and what could be done to mitigate those?
Artesunate is generally very well tolerated. I think across the years, we've been using ACTs for almost 20 years now. And the level of side effect is quite low. In the literature, it is described that you can have some kidney failure and some hemoglobinuria. Jaundice as well is described in the literature, but they are very, very, very rare.
Thank you. There is another question. Is there a scenario for multiple doses of RAS to be used to treat severe malaria by either the CHWs or the HCWs in the health facilities?
At health facility level, I think the recommendations are clear, the guidelines are clear. There is a switch to parenteral artesunate that is recommended, definitely. It is only in case that those conditions are not in place to go by the guidelines that multiple doses of rectal artesunate can be used. So at that point, it's actually the practical judgment of the health workers that would apply. But the guidelines are clear about when all the conditions are in place, there is a switch after the referral dose, switch to parenteral artesunate. And once the child is start recovering and getting able to swallow, switching to ACTs.
Many thanks, Andre. The next question is, did you observe an increase in malaria cases in the provincial health system since the community, and I understand health personnel, were retrained and or sensitized about malaria symptoms, including severe malaria? So in that sense, did you find an unexpected increase in malaria incidents that otherwise, without the RAS program, would not have been registered? It's a really interesting question. As it focuses on the Zambia experience, I wonder if Kathy or Ernest, you'd like to respond to that one.
Kathy, would you respond?
Yes, I think based on the data that we collected as part of the pilot, there was an increase in awareness of malaria and an increase in use of community health workers for certain. But I would refer our audience to the 2 WHO bulletin articles that we wrote on the pilot and the scaled up intervention, and all the information, the data that we collected during those 2 interventions are summarized in those 2 articles. And we can certainly send those out with other materials that we're going to be circulating after this webinar. Thanks very much.
Thank you, Kathy. It's wonderful to see the amount of questions, and with 92 participants, just to reassure you all, any questions that we don't answer, we will do our very best to follow up on email with you afterwards. So please keep the questions coming. I'll take at least 2 more if time allows. Next question, is RAS a molecule which may transition in the short term since it's been in the market for a while? And there's a second part to that question. Is getting funding for this product a challenge in this experience with Zambia and other countries? Perhaps Andre or indeed Kathy would like to respond to that one. Question about RAS as a product on the market and also about funding, and it's a challenge to get money to procure this drug.
Maybe I'll take the one on availability, if I may summarize availability of RAS. I think there are currently two pre-qualified manufacturers, and we could see in one of the slides presented that at some point in one of the years, we went up to 3 million suppository distributed. So there is capacity, there is production capacity. There are two pre-qualified manufacturers, and they are just waiting for the demand, and it can be fulfilled anyway.
Fantastic. Thank you very much, Andre. And I can see there's some comments from Dr. Busiku Hamanza in the chat as well. Thank you for those. And you're asking, you may have missed it, and apologies in advance, is there guidance on costing? There is some guidance in costing, indeed, in the guidelines. There's a question in French come in here. Is it necessary that the CHVs do a rapid diagnostic test to be sure if that's positive before giving rectal artesunate? Hopefully I've translated that question correctly, and it's a very relevant one. We know different countries have different protocols. Ernest, could you give the Zambia experience on whether it's necessary to do an RDT before administering RAS and what the global guidance is on that? Thank you.
Okay, thank you. I think in Zambia, the guidance has been that RAS is a pre-referral, and it can still be administered based on the signs and symptoms, but RDT has to be a must. So it doesn't encourage waiting for the RDT results. So RAS can be administered to the child with signs, and then RDT results can still go together with the patient so that the health facility staff can lead the results and then provide the diagnosis and advise the family. Yes,
thank you.
So that has been the rule in Zambia.
Thank you so much, Ernest. There are questions about storing RAS, quite a few coming in on the Q&A and the chat, so we'll put something in that in the follow-up email. Last question that then we'll hand back to close out. I would just ask, there's a few questions coming in about, can RAS be used for children less than 6 months?
Yes, I think based on the revised guidance for the use of RAS, I think that was in 2021. The age group for rectal changed from 6 months to 6 years to 2 months to 6 years.
Thank you very much, Ernest. Thank you for those excellent questions and really high engagement. Due to time, I'll need to stop there. We'll send more information out, and I'll pass you back to my colleague, Andre, for the closeout. Many thanks.
Thank you very much, Caroline. And it's good to see all the questions coming up, confirming the interest into this topic of the management of severe malaria in remote areas. I think the guidelines are available. They are on the Severe Malaria Observatory website. Of course, this is a living document. Many needs to be improved. So definitely feedback from everyone is welcome to see how we can improve this. And we'll be monitoring the downloads since the Severe Malaria website is hosted by MMV. So we'll be looking at all that. The feedback are very much welcome. It is a document that is out there, that is for all of us for use, and we'll be very, very happy to get your feedback. All the questions that are in the chat and that were not responded, as Caroline said, will be responded. So you will receive response from this. So thank you very much to all. Thank you very much to all. Thank you for your time this evening. At some point, we were 99 people connected. Please share your feedback, and thank you for your time. Thank you to the Transaid colleagues who have worked hard to develop this. But as I said, it's not yet a perfect document. Your comments, your recommendation will be welcome to improve it. Thank you, and thank you for joining.